All right, y'all. This is going to be lecture 15. This is going to be because we missed, I think it was last Monday, right? So this will be the final lecture in Unit 4, and this will be about health and welfare. You should be able to follow along with the slides because I'll post the slides on the Canvas board. Okay, so slide 2 is about life expectancy in 1800. You can see that the global average is about 29 years old. Diseases run rampant. We do not have bacterial disease, bacterial theory, germ theory, cellular theory. All of these things are in the future, right? So um, uh, there are very, very high infant mortality rates, very high rates of death of children, and just generally pretty miserable life, right? Because of disease and dysentery and unclean water, etc., sort of run rampant across the world. Okay, moving on. We move on 150 years. We're at 1950, so this is just post World War II. We have discovered vaccines. We've discovered germ theory. There are massive innovations in healthcare, etc. So you can see that life expectancy is doubling or more, mostly across the world. At this point, the global average has moved from 29 to 46, an additional 17 years on average. But it is the lesser developed regions on Earth that are dragging that average down. So mostly like the Indian subcontinent and Africa. Um, but you can see that Europe and North America are making major, major strides in life expectancy. Okay, we move on to life expectancy in 2025. And you can see here again that North America and Europe are doing the best generally. Europe tends to do better than the United States. We'll talk a little bit about that in a minute. You can see there that like South Korea and Japan are doing very well. And then South Africa, I mean, not South Africa, South America is sort of catching up a little bit, right? Okay, slide number 5, life expectancy today. So this is life expectancy from 1980 to about 2021, just post COVID. And you can see that there was a dip due to COVID basically across the world, right? And yet the United States tends to lag behind the average by about, I don't know, 4 years or so. 3 or 4 years. And then the United States, because of its rather terrible response to COVID, saw a major dip in life expectancy in 2021. Okay, slide number 6 shows you life expectancy across the United States. So the greener you are, the better. As has been a trend, generally the South is doing worse than the rest of the country. There are a few reasons for this. One is the refusal to opt into the Obamacare, the Affordable Care Act system. Another is their very high requirements for eligibility for some programs. And another is they have uh, very high proportions of Black citizens, and as we'll see, Black citizens tend to have lesser coverage in insurance and tend to have worse health outcomes in America. Okay, slide 7 is life expectancy versus per capita healthcare expenditures. So this is just a nice mapping out of how much does each country pay on average per citizen for healthcare. And you can see that it's pretty high. If you look at sort of the developed world, which is sort of the grouping up at the very top of the board, Switzerland, Sweden, Canada, Luxembourg, etc. They tend to spend around, I'd say, about $6,000 to $7,000 per average per citizen. and they're living to be about 81 to 83 years old on average. Now, the United States is on the very far right of the board, right? We spend absolutely by far the most per population or per citizen on healthcare, and yet we have worse healthcare outcomes at about 76 years old on average. And this is highly dependent on race and income as well. And a lot of this has to do with the way that our healthcare industry is set up and the fact that the vast majority of this grouping at the top of the chart have single payer systems, right? A universal healthcare system. And the research shows that, yes, while there are some problems with the universal healthcare system, like timeliness of access, things like that, you tend to spend a lot less and you tend to get much better health outcomes. And so I think the research here is pretty strong that the single payer system seems to be the best way to go, not only because of the health outcomes, but also because of the um, sort of agglomeration of all the bureaucratic processes into just one system instead of dozens or hundreds, which is very costly in the United States system. Okay, moving on. Slide 8. This is a picture of the racial breakdown in the United States and the average lifespan for each racial group. So you can see at the very top of the chart are Asians at about 83 years on average and moving up to about 85 or above in the more contemporary times. Latinos follow them, and we'll talk a little bit about why that is, even though they don't have as high access to healthcare as whites. But you can see Latinos are around 82 years on average in the United States and rising. And then the next line is white and average. They sort of overlap, right, where the black line is the average. And then at the bottom of the chart, unfortunately, we have uh, our Black citizens and our Native American citizens. And you can see that there's a pretty wide gap between Black citizens and the average of about 2 or 3 years. And then especially between Black citizens and, say, Asians or Hispanics. Okay, the next slide, slide 9, shows life expectancy by state, and it is compared to the white life expectancy, right? And so if you look at the lefternmost map, it shows Latino or Hispanic life expectancy in the United States relative to white life expectancy. And you can see that Hispanics tend, just like the former chart I showed you, Hispanics tend to live a little bit longer despite having lesser access to healthcare in America. And a lot of research suggests, at least the research that I've read, that suggests it's because of the way that their family structures are built. That largely the white sort of culture in America is to sort of enter your elderly parents into a nursing home or etc. Whereas Latinos tend to live a much more intergenerational household style, right? Where you might have grandma in the house or grandpa in the house helping to raise the kiddos, these sorts of things. And so the idea here is that the family has a much better understanding of how grandma and grandpa's health should be, right? Or even mom and dad's or whatever, right? They much more than just like a someone who would be checking in a nursing home or something like that, right? They're more aware of their cognitive abilities. They can see small blemishes that might be skin cancers or things like that. And so the intergenerational structure of the Hispanic household tends to allow them to catch diseases, things like that, and to get grandma and grandpa checked up on a little sooner. So, kind of an interesting thing. The research again suggested sort of this intergenerational household effect. Now, if you look at the rightmost map, you can see Black citizens compared to white citizens' health outcomes. And you can see that Black citizens tend to do much, much worse. And a lot of this has to do with poverty. It has to do with a lack of access to healthcare. Um, so yeah, it's a difficult circumstance in the United States that we should probably be trying to ameliorate. Okay, slide 10. This is just a nice picture of the United States and which which states lack sort of health insurance, right? And you can see that Texas is sort of leading the charge here. Texas, Oklahoma, the South in general. Again, much of this has to do with their unwillingness to opt into the Affordable Health Care Program or Obamacare, however you want to sort of give it its nom de plume. Um, but yeah, after the Affordable Care Act was passed, much of the South, and still to this day, refused to take the federal funding because they would have to reduce their sort of guidelines for who is eligible, right? And so many of the southern states opted not to do that, and so they have a far, far higher level of uninsured than does the rest of the nation on average. Okay, this is slide 11 is about insurance coverage by race. And you can see that Hispanic tends to be the highest. So I guess I was wrong about that, actually. That's very interesting. I did not know that. And then we have, let's see, non-Hispanic Black in the next bar, and then non-Hispanic White. And, here you can just sort of see how it breaks down. And some of this has to do with Medicare and Medicaid. Um, Medicare and Medicaid. Oh, yeah, this is uninsured. So, yeah, I was right. Hispanics are the highest level of uninsured, right? Um, uh, but you could also see that after the passing of Obamacare, the Affordable Care Act, you saw a large dip, about a 10% drop across the board in those who are uninsured. Okay, slide number 12 is child mortality rates. And so this is, what out of 100,000 children, how many will die before they reach adulthood, right? And so you can see Africa is really struggling here, and then so is India, Pakistan, Bangladesh, these sorts of states. Europe, it tends to be doing the best, and so is Japan. And then the United States is doing well. It's among the developed countries, but it's doing poorly compared to the developed countries, right? So it's not terrible, but it's not world beating by any sense either, right? Okay, number 13, international child mortality rate. So this is the OECD, the Organization of Economically, I can't remember. Anyway, it's the group of developed states, basically. There's about 40 of them. And you can see here, like Finland is leading the charge, along with Iceland, with only about 1.8 child deaths per 100,000, or per 1,000, excuse me, versus the United States down at the bottom at about 6 deaths per 1,000. So we are on par with the Slovak Republic, Hungary, and Poland. Not a great place to be. Okay, slide 14, infant mortality per 1,000 live births by state. So this just gives you a nice, instead of an international perspective, this is a US perspective. And you can see that, again, mostly the South, but also sort of the Rust Belt states are all doing pretty poorly in this category. And Mississippi is sort of leading the charge on the number of live deaths per 1,000 births. And this is highly related to the fact that Mississippi is the only majority Black state in the United States. Okay, slide 15, infant mortality by race. So here you can see that again, Asians tend to be doing the best, as we've talked about in this class a couple times. Then you have whites with about 4.8 deaths per thousand births, excuse me. And then Hispanics, and then the average is about 6, right? Just like that other chart we looked at. But then it starts to get much worse with Native Americans and especially African Americans, with about um, uh, about 11 in every 1,000 births resulting in death. Okay, slide 16. So the top left chart is the average monthly participation in WIC, which is Women, Infants, and Children program. This is meant to give not only sort of medical advice and a little bit of healthcare, but also just some basic nutritional needs like milk and cheese and some like fruits and vegetables. It's a pretty small outlay, but it goes a long way from what the research shows. And you can see that the majority of those who are involved in WIC are children, of course. You cannot be in WIC unless you are a mother with a child. And you can see that it rose from 1980 until about 2012, but then its usage has sort of dropped since then. The far right chart, total Medicare private health plan enrollment from 1992 to 26. This is Medicare enrollment. So as you can see, Medicare enrollment has been increasing dramatically. Medicare is for the elderly and the disabled. Medicaid is for the poor and disabled. But there are two different programs. Medicare is for elderly. Medicaid, we care for the elderly, we aid the poor, right? It's kind of an easy way to think about it. But as you can see, Medicare enrollment has been increasing dramatically over time. And a lot of this just has to do with the fact that we're living longer, right? And so as Americans live longer and longer and longer, you'll have more people on the rolls of Medicare because you become eligible at 65 years old, right? Medicare is a federal only program, unlike Medicaid, which is run by both the federal government and the states. Medicare is only federal. LBJ instituted it in 1965 during sort of the Great Society, the War on Poverty. This was the same time we were pushing the Civil Rights Act and the Voting Rights Act. And again, it's for the elderly and disabled generally. WIC is also a federal program. Again, it's for women, infant, and children. It's mostly food benefits. I remember when my daughter was born, we had WIC and we got, I think it was like 4 gallons of milk a month and like a pound of cheese and a couple of fruits and vegetables. But I mean, it came out to like $60 a month or something. And this is paid for by the federal government, but administered by the states. Okay, government funded healthcare number 2, Medicaid. Remember, Medicare is for the elderly and is federal only. Medicaid is for the poor and is federal and state, right? Medicaid was also instituted in 1965 under LBJ. It is for low income, pregnant women, and people with disabilities, especially those who cannot work. And so you can see here that Medicaid has largely been rising over time, Medicaid use. And a lot of this has to do with the high levels of inequality in our society that are growing seemingly every year. We are getting a larger and larger portion of American workers who simply cannot afford, I don't know, healthcare, rent, I mean, all kinds of things. So, as that continues, we are seeing a continuation and an increase in the use of Medicaid. Okay, slide number 18, Social Security and Medicare constitute more than a third of the budget. So this is just the federal budget for fiscal year 2022. So this is a couple years ago. And there are some interesting things to point out here, right? So Social Security makes up about 1/5 of all of our government spending. Medicare and Medicaid, when you put them together, make up about another quarter of all of our federal spending. Then you add defense, which is another 13 to 14%. And basically, the only thing that you have left, only 16%, and some are saying as low as 14% of our current federal budget is sort of discretionary, right? Like 86% of our budget has been decided already historically, right? Like there's nothing we can do to tinker around the edges, like it's law. So it's very interesting, especially with the sort of Doge stuff going on right now. Um, there's a lot of concern on both sides, like even Republicans, that Elon and Trump are going to start going after things like Social Security or Medicare, which are basically sacrosanct in the United States, right? Because they're for the elderly, and the elderly are by far the largest voting bloc, and they voted the highest percentage. So, um, even conservatives are pushing back a little bit, like, let's not mess with Social Security, right? So, yeah, it'll be interesting to see what happens in the next few years. Okay, slide number 19, the Affordable Care Act. So in 2010, Obama passes the Affordable Care Act after much consternation. This expands Medicaid pretty dramatically, right? And basically, the idea is that states can opt into the program. And if they do, the feds will pay 100% of any additional enrollees for the first 3 years, right? And then after those 3 years, forevermore, the federal government will pay 90% of the cost. However, in order to qualify, states have to lower their standards to the federal poverty level, right? They cannot sort of institute their own standards. And because this was one of the problems with Medicaid before, is that states would say, um, if you make $15,000 a year, you're not eligible. Well, like that makes it very difficult to have health care, right? And so the idea here was, okay, we'll foot almost all of the bill if you'll allow more people to enter into eligibility. Um, and during the 2024 per annum year, this was $31,200 for a family of four, right? So if you made less than $31,200, you got a family of four, then you're eligible for Medicaid. But for the most part, the South 100% opts out, right? And a few states have since changed their minds. I think Kentucky is one of them, right? Because they have Democratic Governor Andy Beshear right now. Even though they're a pretty red state, there are a lot of poor people who are either centrists or even Republicans who are saying, look, we need health care. And so the Democratic governor sort of pushed it through. But most of the South has sort of refused on ideological grounds, right? Or even just fury that it was something that Obama succeeded at, right? Um, there are some results for participants. Their hospital costs have tended to be reduced, right? One of the great things about this program is that the federal government is actually paying for goods rendered. And so the idea here is that a lot of these goods are going to be rendered whether these people are covered or not, right? Like emergencies happen, people get sick, people get a broken leg, people get a broken arm, shit happens, right? And so these people are going to be going to the hospital one way or another. And so the idea here is that when the states that do get coverage from Obamacare, hospital costs tend to go down, right? Because there's more payers into the system. There's fewer sort of free riders, we call it in economics, right? Fewer people just bumming off the system. And so hospital costs go down because they're collecting more. You get millions more covered, millions more citizens. You tend to get better health outcomes, is what the research shows. We get lower, not birth defect, but infant mortality rates and lower death of the mother during infants or during birth. And they changed the rules to say that youth can stay on their parents' insurance until they're 26, and that used to be 18. So you get an additional 8 years while you're in college and these sorts of things where you can be on your parents' coverage rather than your own. Okay. Number 20. I know this is kind of a ridiculous advertisement, right? But that was kind of the point. I wanted to show you like just how horrible and silly these things were in like the 1980s, these advertisements, right? So yeah, this was a really funny example. There's a much more sort of touchy example here in a minute. So okay, anyway, other state and local healthcare costs. Medicare, Medicaid, excuse me, and Obamacare also expanded some subsidies to hospitals for emergency room care, ambulatory services on helicopters, health information and preventative health, anti-smoking and drug campaigns, blah blah blah. Right. So there's a lot more there than just health insurance. Number 21, early American healthcare. So we're going to go through sort of the history of healthcare in the United States. Um, in early American healthcare, this was largely provided locally, right? These were generally like church services or orphanages and almshouses and things like this. I mean, there were very few sort of professionalized hospitals. They did exist, but they were brutal. You have to remember there weren't really painkillers. We didn't know much about how the human body worked. Um, it was pretty rough, right? And they were spreading diseases back and forth inside these hospitals because we didn't really know much about germ theory, right? So medicine starts to slowly evolve. We get to the Civil War era. We know that a lot of the research and a lot of the history of healthcare is pretty misogynistic, right? Very male body based, very white body based, right? There are still complaints even to this day about this sort of thing. Almshouses sort of evolve into early hospitals, right? Again, though, they're pretty dirty. This is when we start really separating and making the distinction between the physically sick and the mentally sick, and asylums start to appear in the United States for the first time. Um, let's see. And I would also point out that for the most part, hospitals were for the ultra poor, right? Um, you did not want to go to a hospital. They were filthy. There was screaming everywhere. There was disease and blood all over the place. It was not a pleasant place to be in, right? The wealthy had private house calls where doctors would come to their home and see them and their families, right? And it was cleaner. You got a lot better attention and care, these sorts of things. So, if you were wealthy, you would not be found in a hospital. Okay, slide number 22. We're moving on to the progressive era. So remember, this is around the 1880s to about 1920. Excuse me. Um, Basically, Europe is passing these social security systems, pension systems, the National Institutes of Health, these sorts of things like these universal healthcare systems are starting to arise in the European system. Unfortunately, some labor unions and some sort of medical unions push back against this idea in the United States, right? So the AFL-CIO is staunchly opposed to this idea. They want private insurance. In the 1920s, we get the first sort of workers' comp and the first sort of labor laws come onto the books, right? It's not actually workers' comp. It's like a predecessor, a weak predecessor to workers' comp, but it was like the first initiation. This is when we're getting this is the early industrialization period. There's a whole lot of like work injuries, not only from machinery, but also from cuts and blood poisoning and all of these sorts of things. There's a lot of usage of dangerous chemicals at this time, right? Because there are no real safety regulations in place. There's no labor laws, right? There's no like maximum work week. There's no labor laws against children working. Um, Children, again, because they have small hands, they're able to work more easily on the machinery, and so you're seeing a lot of children become crippled, right? Losing a hand, losing an arm, these sorts of things. And then we get a lot of things like blood sicknesses, tuberculosis, things like this from being, especially on sort of the cutting room floors at meat factories, right? Where a simple cut will turn into a blood poisoning and a death, right? Um, these sorts of things can be really problematic. And because conditions were so not only unsafe but also unclean, you got a lot of disease, right? Tuberculosis and dysentery and things of this sort. Then the Great Depression hits. So we see the Great Crash at the end of the 1920s. The end of the beginning of the 30s starts with the Dust Bowl, the Great Depression, huge bread lines, 20 to 30% unemployment, and so this is when FDR comes into office, Franklin Delano Roosevelt, and he really starts to initiate some very leftist policies, right? This is when we get unemployment for the first time. This is when we get Social Security for the first time. This is when we get AFDC, aid to families with dependent children, right? So there's all these programs in there trying to put money in people's hands so they can not only feed themselves, but also pump money into the economy, right? So this is sort of demand side economics from John Maynard Keynes, whereas everything before had been supply side, right? Let's build up factories, let's build up production. Well, if no one's buying shit, then that doesn't work, right? And so FDR really, for the very first time in history, push demand side economics, right? Put money into people's hands so they can spend it. And it will not only benefit them, but it will benefit everyone economically when they're spending their money. This will allow factories to ramp back up, to hire more people, etc. Right? Okay. Slide number 23, modern American healthcare number one. So first, I just want to sort of talk about LBJ's Great Society and his war on poverty. We've mentioned it a few times in this lecture. In 1965, we passed the Civil Rights Act, the Voting Rights Act. We pass the Medicare program, right? Medicare, again, is 100% federal, but there are limits, right? You have to have been working for 10 years and you have to have paid your taxes for 10 years, right, to be eligible. Medicaid, again, is jointly federal and state. About 60% of the funding comes from the federal government. It is administered by the states and they determine eligibility. And so here you can see sort of what I was talking about earlier with eligibility. Um, if you're at the very top end, right, Minnesota, this is for a family of three. If you're in Minnesota, you can make $42,000 a year and still be eligible for Medicaid. If you are in Texas, let me find Texas. Oh, Texas is way at the top. If you're a family of three and you made more than $4,900, you're not eligible, right? In Arkansas, the worst state of all, uh, if your family made more than $3,100 last year, you can't get Medicaid, right? So the Medicaid eligibility varies widely, right? Okay, this really touchy political cartoon here, but this sort of gives you an idea of the discourse that was going around during the 1980s. There was some really disgusting shit being said, right? Um, so eligibility is increasing, right? More people are on the rolls of Medicare and Medicaid. Um, and so this is increasing the federal budget, right? And so during the 1960s and 1970s, 1980s, the roles are increasing because we created these programs in 1965, but also life expectancy is increasing, right? And so more people are getting on the rolls. Well, when Reagan comes into office, he starts some just really fiery and arguably hateful rhetoric against black women, basically. Demographics are changing at this point, right? We went through sort of the hippie movement. Divorces are increasing dramatically in our societies. Single mothers and never wed mothers are also increasing dramatically in our society. And Reagan comes out and starts calling them quote unquote welfare queens, right? These moms who are just pumping out a bunch of kids and driving around in a Cadillac on government money, right? It was pretty gross stuff. There was very little truth to it. But in the late 1980s and early 1990s, Reagan and then also Clinton later start pushing cuts, right? So cuts are introduced to the programs in the late 80s. You start getting work requirements. You start getting truancy restrictions, right? So, like if your kids aren't going to school, you get cut off. Uh, some of these things are pretty acceptable, I'm guessing, and then you also get time limits, right? So if you're on, say, Medicaid, or if you're on something like TANF, you will have time limits from 6 to 18 months where they'll kick you off the rolls. And then in 1996, so this is under the Clinton administration, AFDC is disbanded, right? TANF is created, Temporary Assistance for Needy Families. So basically, they replaced AFDC with TANF. You have federal work requirements, so you have to have, worked for a certain amount of time, and you have to be looking for a job or whatever. You have a 5-year benefit cap, so you can only get TANF for 5 years of your entire life, period. We don't care if you lived 140 years old. If you used your 5 years, you've used your 5 years, right? Um, and there are no federal requirements on states, right? So states just get a block grant, they can spend it however they want. Uh, it gets weird though, right? That kind of idea where you can just like spend the money however you want, it it brings up some problems. Okay, the next slide, slide 25. TANF is meant to help to alleviate poverty and homelessness, right? This is a program that's supposed to, for the most part, be used for exceptional circumstances, right? You've lost your job, um, you've lost your rent, you get a devastating disease or something. One of your kids is in a coma, like some sort of like devastating emergency, right? Um, and so eligibility requirements are pretty stringent, right? So again, Wisconsin, which tends to be the most giving state, as we saw earlier, right? They have the highest limit for those who are eligible for TANF, right? So if you're a single parent and caring for two children, um, your eligibility is around, what is that, $1,700 or something? And then on the other end, in Alaska and Arkansas, if you make around $280 for the month, then you're not eligible, right? Okay. Slide number 26. Okay, this is where we're talking about how things get a little strange with the TANF program. So the map here is the maximum monthly benefits for a single parent caring for two children. So it's so related to what we saw just a moment ago, except you get a nice visual. So here again, Wisconsin is the highest, Alaska, New York, but then you also get in the very south, you get sort of the very lowest levels of eligibility. Benefits are tend to be incredibly low, right? Like in Texas, I think you can get $240 one time, right, is your TANF benefit. That's not going to help a lot of people get through much. Some states are sort of gaming the system, right, using TANF donations to spend elsewhere. So they'll just take those TANF dollars and spend them on other programs. We are also finding out that some of these funds are being used to subsidize things like college applications for wealthy students. In with the argument that it's going to work needy families, right? Some of them are going to drug courts. We have also found out that millions of dollars were stolen from the program in Mississippi. Somehow, also, Brett Favre got more than $1 million, the former Green Bay Packers quarterback, for speaking engagements that he never even showed up to. There's been some really strange stuff there if you're interested in looking that up. And then finally, there's been some interesting, like, healthy marriage initiatives that, again, they argue that are tied to helping needy families. Uh, and this is mostly from Oklahoma. And so it sort of pushes this sort of, I don't know, cisgen nuclear family idea. It provides marriage counseling and even like free retreats for couples, and then abstinence only program. So just some weird stuff that this money is being spent on. Okay, finally, we'll end with sort of abstinence only because it's tied to health. So the South, for the most part, does not allow teachers to talk about things like condoms, HPV vaccinations, you know, any of these sorts of things, right? They can only talk about abstinence. Like the only way that you can protect yourself against disease and pregnancy is abstinence, right? And this program has pretty devastating effects on the South, right? So here you can see teen pregnancy rates. Obviously, the South is leading the charge on teen pregnancy. On the next slide, you can see rates of STDs. Again, the South tends to be leading the way, especially Louisiana and Mississippi. The STDs included here are chlamydia, syphilis, and gonorrhea. And then the final slide shows you HIV rates. And again, it is largely the South and California leading the way on HIV rates. And a lot of this is just to do with lack of information, right? Not teaching kids about safe sex practices, the consequences, etc. So, I'll leave it there. Thank you so much for being here for the day. I will get these slides up and I will see y'all Wednesday. Have a great day, y'all. Thanks.